Good afternoon. My name is Vichayasit Tantayapong. Today I'll be presenting my work on pulmonary venous quantitation predicts mortality in early lung fibrosis. So fibrosing interstitial lung disease is a growth disorder characterized by diffuse scarring of the lung tissue. It has a highly heterogeneous clinical course and an unpredictable trajectory with a poor prognosis of 3 to 5 years post-diagnosis. Some of the key clinical, prognostic factors are the patient's clinical conditions, the decline in pulmonary function tests, the distance walk, or high-resolution CT scans where we look at lung patterns such as honeycombing, reticulation, and perform a visual estimation of the fibrosis involvement and then calculate into a score. While high-resolution CT scans is offered as a diagnostic tool, it is not offered as a screening tool. So Mayo Clinic developed this image analysis tool called Caliper, which quantified these lung parenchymal findings. And one of my supervisors' previous work, he looked into these computer-based CT analysis, and he found that it outperforms the traditional visual scoring metrics in predicting mortality, specifically volumetric quantification of pulmonary vessel volume or pulmonary vessel volume, PVV, which established itself as an independent predictor of mortality in fibrotic lung diseases. But the problem with pulmonary vessel volume is that it combines the arteries, the veins, and the fibrosis. So when it increases, we don't know exactly which one's causing the increase. It could be the arteries, could be the veins. What we can do is we can apply a segmentation algorithm to a low-dose CT scans and then quantify the vessel volume of each vascular tree separately. So our objective of this work is to develop an automated segmentation model that quantifies the pulmonary venous system, then assess the prognostic importance of baseline vein volume from low-dose CT scans of ILA patients. And ILA, or interstitial lung abnormalities, is an incidental CT findings that represent the early stages of pulmonary fibrosis. It is associated with increased mortality and have shown to progress over the years. So our population is from the SUMMIT study, which is a lung cancer screening study in the UK that recruits individuals with smoking history to perform a low-dose CT scans, and that ILA is a common finding in this population. Then I perform a manual annotation slice by slice of the CT scans under supervision of a radiologist, and then train the model using an NN unit, which is a deep learning-based segmentation model that can adjust its pipeline automatically to the data fingerprint, and then utilize a unit architecture, which is a type of convolutional neural network, to create a segmentation model. So in our first round of training, we used 20 annotated CT scans, emphasizing on the central connectivity between the intrapulmonary vessels back to the heart. Then we used another 20 annotated CT scans, now focusing on the peripheral, on the distal connectivity. Once we have the second model, we quantify 417 ILA CT scans and 404 control CT scans and express the vein volume as a percentage of the total lung volume. To assess our performance, we use a Dice coefficient score, which is a similarities between the prediction made by the model and the ground truth labels, where 0 means no overlap and 1 meaning perfect overlap. And our model performed relatively well, achieving increasingly higher Dice score of 0.876 in the first model and 0.906 in the second model without overfitting or underfitting. From visual inspection, we can see that the first model regains that connectivity from the intrapulmonary vessels back to the heart. Where in the second model, you can see that there's less noise on the peripheral compared to the previous ones. Once we quantified the CT scans, we found that vein volume in ILA cohort is significantly higher of 2.09% compared to 1.89% in the control group. Whereas in the predicted FVC, which is a good indicator of severity and progression, show no difference between the two cohorts. In univariable Cox regression analysis, increased vein volume is associated with increased mortality risk of 2.86. And once we adjust that to age, gender, smoking history, and predicted FVC, the increased vein volume remains independently associated with increased mortality risk. We also did analysis on each cohort separately and found that the association were maintained within the ILA cohorts, but it was not maintained within the control groups. So increased vein volume in ILA cohorts and its association with increased mortality risk may suggest that vascular remodeling could be an early pathological sign of pulmonary fibrosis. And many studies have backed this up, finding that within the fibrotic foci of IPF patients, they show distinct vascularization patterns. So in fibrotic regions, show reduced vascularization and arterial alterations such as elastosis, muscularization leading to obstruction of the vessels, and then compromising the oxygenation. whereas in the non-fibrotic regions show increased vascularization, dilated capillaries, and occlusive venopathy. We believe that it's an attempt to protect and regenerate the alveolar walls against the fibrosis. Some of the limitations, I think, is that we didn't really comprehensively analyze the cause of death and the potential confounders, such as the lifestyles and comorbidities. There's also no healthy control groups for comparison, since all populations are smokers, and also the baseline nature of vein volume didn't really capture the temporal progression of the disease, and also limited annotated training data set because the annotation itself is highly time intensive, and then I could have done post-processing to remove the remaining noise. But our future work aims to use our in-house software called AirQuant, which identifies and detects the branching point of the vessels and then classify it into lobes, allow us to study the vessel generations within each lobes, and then allow a regional quantification rather than a global measure like the pulmonary function test. We can also do what we call skeletonization, where we look at the morphological features of vasculature trees, such as the tortuosity or the tapering or the dilating effect of the vessels. So in conclusion, pulmonary vein volume demonstrates prognostic value in predicting mortality in early lung fibrosis, and I truly believe that computer-aided quantitative image analysis may allow us to derive novel imaging biomarkers for fibrosing interstitial lung diseases. Lastly, I want to thank you, my supervisor, Dr. Joey Jacob, Dr. Gabriel and Dr. Marin, and everyone at the Satsuma Lab for helping me out in this project. Thank you.
A heartfelt thank you to our presenter. Next is the questions and answers session.
Thank you for interesting image. How do you plan to imply your work to help the patient's management?
So I think it's very beneficial in drug trial setting first. So initially, when we have lung fibrosis, we can either do lung transplantation or palliative care. And then recently, there has been a trial in 2014 showing that anti-fibrotic therapies have shown to slow down the decline in FVC. So what I think will be very helpful is in drug trial setting, we can use this and identify participants that could reach the endpoints. So they're at risk of progressing, and then we can see whether the drugs could really help. I think it's also important because the prognosis is really bad, 3 to 5 years, and also a diagnostic delay of 2 years. So I think an early screening, an early intervention would really improve the quality of life because the trajectory is unpredictable. And I think it's really important we provide the patients with drugs to help them with their clinical course.
So can I just clarify the method a little bit? So you got the cohort data of someone who smoked for 20 years, but is that right to use for the model? Or?
So the population is from a summit study.
Yeah.
It's a lung cancer screening that recruits patients with significant smoking history within the 20 years to perform a low-dose CT scans.
So this is a sub-study of the main cohort. How can you select this group of the people to do for this?
Can I go back?
Yeah, please go ahead. I think you mentioned a little bit, but I was not quite clear.
Right. So we kind of pulled the data from the study, and then we try to select all kinds of level of severity from mild, moderate, and severe. And so different subtypes of fibrosis, such as FILA, UILD, and then we try to make it equal so that the model can quantify different ranges of level of fibrosis. But, sorry.
So because you said that you don't have control, right? But when you present data earlier, I saw you have ILA case and controls and how you select only the cases to use this model.
So by control, I mean there's no ILA. And ILA cohorts means, by healthy control means we don't have healthy non-smokers. Yeah.
I see, okay.
But the important is from ILA because it's an early pulmonary fibrosis, so we want to detect.
So everyone's a smokers, but then you categorize whether they ILA and control cases. I think you sort of said that, but not very clear to me, but thank you very much for that.
The study population is only smoker, right?
Yes.
It's not including because I'm the pediatric oncologist, so this kind of study maybe is very useful for the pediatric patient that using the chemotherapy that have like lung fibrosis in the later time. So what do you think like that you can apply this research to another kind of population?
So actually, our model actually is applied to other lung diseases such as IPF and also COPD. We're working on COPD as well as, sorry, I have brain block. We have COPD, we have IPF, and then hopefully into other lung diseases. Sorry.
Okay, excellent. Thank you very much.